Good morning, good afternoon. This is Greg Cosgrove, the Pulmonary Fibrosis Foundation. I'd like to welcome you to our ongoing conversation about COVID-19. And we had a tremendous response several weeks ago with Drs. Amy Case and Sonia Danoff, and we're frankly overwhelmed by the number of insightful questions. And so we have a follow-up conversation to really begin to address some of the additional questions that have come in and the timely changes which seem to occur almost daily with our understanding of COVID-19 and its impact on our community. So I'm very pleased to introduce our guest today that will facilitate additional conversations. And we have Ms. Delarosa, who is a PFF Ambassador and a strong advocate for the community, not only in San Antonio, where she lives and really orchestrates an integrated network of patients and supports them, but also nationally across the country. She was one of our co-chairs of the PFF Summit this past November. And joining her, we have Dr. Ryan Boente, who's at the Indiana University Health Center, and he's really instrumental in their interstitial lung disease clinic and has expertise across a variety of different diseases, as well as transplantation medicine. And then I'm joined by Dr. Amy Case, who is head of the interstitial program at Piedmont Healthcare, and really facilitated a tremendous discussion last week. So to start off, I'd like to welcome them and thank them for taking their time during troubled period in medicine to join us and share their thoughts. So thanks for joining us today, guys. And so I think what we'd like to do and start off with is maybe bring the discussion really back to you, the caregivers and providers and patients. And I thought that perhaps we can have Dr. Delarosa describe a little bit of her experience, because I think probably what she's going through from a patient perspective is similar to what many in the audience are going through. So Dot, maybe you could share a little bit about yourself and how you've been handling, pretty difficult time throughout that's affected all of us, regardless if we're patients or not.
Thank you, Greg. Hello, everyone from San Antonio, Texas. Patient to patient, I totally understand what a lot of you are going through, you patients and even the caregivers. When we are diagnosed with pulmonary fibrosis, which I was diagnosed back in 2008, we began to already start preparing for so many things. We start preparing almost for the end. I hate to say it, but bluntly, because we know about this terrible disease. So we start to already mentally and physically and for the future prepare for what's, plan B and C and D, MC, A, B, C, and D. And so this is nothing too scary for us. It's just an addition to. We are already used to not being around sick people. We are already used to protecting ourselves using hand sanitizers. You see this photo up there of me checking the mail. I have gloves on. I have my mask on, and I'm definitely sanitizing everything. That's nothing new, my fruits, my vegetables, we sanitize those. Anything that comes in, we just kind of sanitize it. But this is just an added, burden, I guess you could say, upon us and the world, but it's definitely nothing new. It does help us to reflect and kind of bring it closer to us again. But as a recipient, it is, a challenging time for us, for our family members. But I just want to inspire y'all and encourage y'all today that just continue to live as you are, be at peace about it. For those of you that haven't prepared, this is just a time, or that you have prepared for the future, such as, having your wills done, making sure that, you have your preparations, what's going to happen if you have to go to the hospital, that someone's caring for your loved ones, or what's to happen. Just follow up on that and kind of update it, your wills, if you need to update those, and just be prepared, but be encouraged as well, because I think for me, and perhaps some of y'all as well, the worst diagnosis that we could have ever gotten in our life was being diagnosed with pulmonary fibrosis. That was our death sentence. So anything after that, it's like, oh yeah, whatever. Well, we can overcome that. So I just encourage you today to just, continue to breathe, continue to be informed. Thank God for the pulmonary fibrosis. Thank God for any information that's out there to help us to be more aware, be aware of your surroundings, keep inside, self-isolate. I am exercising just up and down my little, my little strip down here, but definitely with my mask and just trying to keep sane. I think also what I'm doing as well is helping my family, my mom, and just making sure she's okay about it, because we live together, and my family understanding, even though I miss them so much, just, saying, hey, I'll see you later. I'll see you next time, and just giving us that opportunity to encourage each other and to, be aware that this is so important right now for them and for my safety and for you guys to just make your family understand that you cannot have, COVID or anything else, a flu or anything coming to you, because that's just going to be an added burden for you and for them. And if we're hospitalized, that's just going to be something extra that we'll have to deal with. So I'm blessed and excited to be here with y'all and ready to answer any questions. And so excited that the PFF has put this on to help us, to encourage us. And please, whatever questions you have, please make note of them. And at the end, we'll definitely be here to help you in any way.
Fabulous, Dot. I think one of the things that we've been curious about, you've touched on that. I think our community adopted the precautions very early in this whole process. And when I talk to my colleagues and love to hear what Ryan and Amy have in their experiences in Atlanta and then in Indianapolis, that the community of pulmonary fibrosis patients has really adopted the guidelines, like you mentioned, in terms of self-isolation and very careful hand hygiene. And fortunately, here in Denver, we have not seen many in our support group that have been impacted by COVID, certainly not as much as the general population. And I guess I'm impressed to see that those measures are working really well. Ryan and Amy, have you seen similar things in your regions throughout the country?
Yes.
This is Amy, and I can attest to that too. Go ahead, Ryan.
I can attest to that just in virtual visits and telephone visits, talking with patients. As Dot said, they've been preparing for this their whole lives, and most of them have been taking it very seriously, and we've not necessarily seen this impact our community of pulmonary fibrosis patients. So it's been very encouraging.
So it's maybe a shout out to you out there that what you're doing is really working, and not only working for yourselves, but for the rest of everyone around you. Certainly, I don't want to dismiss the potential impact that this infection and disease has had on anyone, but more just to kind of encourage you, the great work that you're doing. It appears from our experience working in clinic that our patients are protecting themselves, thank goodness, and perhaps as a global community, that is working, and so we have to continue to do that. And there's a lot of questions about what if in the next step, but until we have better idea, Dot, your enthusiastic support for protecting yourself is what we need to do.
Thank you. Yeah, and our life depends on it, and I speak that for every patient out there. We have to. It's not we should or we maybe. No, we have to. It's life or death for us. So it's of urgent, of this most urgent care that we adhere to these and our loved ones as well.
Yeah, and maybe from your perspective, one of the questions that we get and we got last time is, how do we protect ourselves but still get everything that we need, the groceries, the medications, and where do you draw the line in terms of the essentials of life, but also reducing the risks? And that's, I don't think there's a right or wrong question, but it's really assessing the risks. And how do you do it for yourself down in San Antonio?
Yeah, well, thankfully, my medications are mailed to me, so I don't have to worry about having to go to a pharmacy or picking them up. our hospital, our transplant visits are going to be telemedicine. So that's something that I'm really excited about, because the drama and the stress of having to find parking and then having to walk all the way to the clinic and having to protect ourselves from the people in between. We don't know who has what in the hospital. So I'm kind of excited about that. That's going to be the next stage for when I go visit the doctor. As far as groceries and all that, I have some wonderful volunteers that come and they'll, order it and then they'll pick it up curbside, and then before they come in, they sanitize it, or I'll sanitize it, but normally they'll do it outside and then leave it in the bag, and then I'll re-sanitize it when I come in. But thankfully, like I said, we are already prepared. Toilet paper, no problem. We had our little stash, paper towels, hand sanitizers. We're just prepared. This is our life. We had gloves, masks. So all of that we already had all those things, but the simple necessities of groceries and that, and even ordering. Sometimes, we want to do takeout and we'll go pick it up curbside and make sure that they put it way in the back. I have my mask on. Mama has her mask on. When I get home, I sanitize. When I go to open up the back of my car, I sanitize every single thing that they've touched. Then I sanitize the outside of the foods that I purchased, just to make sure. I bring them inside. I transport them to our plates, throw away the others, and, just to wear. Even when I receive packages in the mail, when I order stuff, via, Amazon or Walmart or what have you, I make sure that I sanitize all that also, have my gloves on, and leave everything out there, and then re-sanitize everything that comes in. So it's just, continual cleanliness and making sure everything's sanitized. That's how we live. And it's just extra and almost, and if I could say this for us patients, we almost feel a little safer that the whole world is just now catching up to our lives.
And Ryan, do you have a similar experience with your transplant patients in Indiana?
Yeah, it's been very similar. I talked with our transplant director this morning, and I think what's helping a lot is just good communication with your transplant team, whether it's your transplant coordinator, your transplant doctor. We're more than happy to help out and with anything that you need. And I think a lot of it's just open lines of communication, and then taking the extra precautions, which most of our patients already do, and then the telehealth visits have been instrumental in this process.
Yes, in a time when we know not as much as we'd like about the coronavirus and how it impacts patients and even the transmission, being careful, I think, is what you're saying, Dot, is first and foremost. The more we learn, then we'll be able to maybe change behavior and be safe about it. But until we learn more about the disease and everything that is involved, being as careful as possible is the best choice, and then using information, and that might lead to kind of the next section that Dr. Case was going to address is really talk about an update on COVID-19. It's evolving on a daily basis. We're learning from our colleagues. I know the three physicians, we're talking to each other, but I'd say there's a network across the country to try to understand the experience in New York City versus that on the West Coast. And that's part and parcel why we have representation from Atlanta, Indiana, and as well as Colorado today to share experiences, and that might be beneficial to you as our patient community and caregiver community. So Amy, maybe we'll transition and you can kind of address some of the new information that's coming out over the past 2 weeks since our last conversation.
Sure. Thank you, Greg. A lot of you, I think, were with us for our conversation 2 weeks ago, but just very quickly, when we talk about the coronavirus or the COVID-19, the coronavirus we're referring to is one of a family of viruses that can cause respiratory illnesses in people and also in animals. COVID-19 is the disease that is caused by the virus SARS-CoV-2, which is circulating now in our world, and is a new virus that was that moved into humans last year, which is why the 19 is there. And over the last 2 weeks, if anybody has seen any of the news, We know that that there's been a lot of spread around the country, and that this is, there are some areas of the country that are in crisis because of the illness that's been caused. And we talked a lot last time we were together about this idea of what can we do to keep ourselves safe, and social distancing is the buzz phrase of 2020, meaning that we keep our distance from people who are not in our households, because we otherwise have really no innate defenses against this virus and the disease that it causes. And so these things that we're doing, we talked a lot about last time, have seemed to help. I will show this now and show that, over the last couple of weeks, we've really seen just an explosion in the number of cases across the world, and particularly in the United States. However, as Greg was saying, the population in the world, and in the United States especially, has been very good with the recommendations for social distancing. And when we talked about flattening the curve, this is the bending that we were hoping to see. The projections that you might have heard about in terms of impact and confirmed cases and deaths, and how we were expecting so many more people to have been affected by this at this point, really those made the assumption that not everybody would be doing social distancing and hand hygiene and all the protective measures like people have. And so instead of, say 50% of people doing what they should be doing, it's closer to 90% of people that are doing what's recommended. And that really has made a difference. And so if I can give anybody encouragement, it seems like as a country on the whole, we may be turning a corner and seeing things get better instead of continuing to get worse at this point. There are areas of the country, I didn't include specific states on these graphs, but there are areas of the country that haven't turned the corner yet, but we're getting closer to that point. And what does that mean on the other side? Probably a lot of continued caution and continued social distancing for some period of time. None of us really knows what that looks like, but the fact is what we're doing is working, and we have to say that thanks to the world, because we're all in this together. And so I thought it was encouraging to show that. So when we talk about, we had a lot of questions, I think last time we met, about the impact of COVID-19 on our pulmonary fibrosis population. And we did mention at that point that what we see as risk factors, not for contracting the coronavirus, because we're all at risk. If we haven't already had it, we're at risk for getting it because none of us has any immunity, but at risk for more severe illness should our pulmonary fibrosis patients have COVID-19. And those risk factors are underlying underlying lung disease, and in some cases age, and in some cases immunosuppression. Now, questions specific to the impact on the community to date and moving forward. Greg, can you talk a little bit about what we know and what we don't know?
Well, yeah, I'd love to. We're trying to acquire data, or the CDC, when patients are diagnosed with COVID-19, information is sent to a central database, and it's shared with all individuals throughout the country in the medical community. And so they characterize chronic lung disease. We don't have specific information about pulmonary fibrosis, as it's not categorized in the questionnaire when patients are diagnosed. Physicians likely will characterize patients with pulmonary fibrosis as chronic lung disease, but two conditions that were identified, one was asthma and one was chronic obstructive pulmonary disease, as specific chronic lung disease. So the question that we've gotten at the Pulmonary Fibrosis Foundation, and I'm sure as clinicians, Ryan and Amy get, is there specific risks for patients with idiopathic pulmonary fibrosis or rheumatoid arthritis associated pulmonary fibrosis. And to be honest, I don't know if we know if the genetics of pulmonary fibrosis has a role in either response to the virus or a predisposition to getting it. That information is just not available yet. I can tell you that the groups in New York that have been really affected by the disease are beginning to acquire information and trying to set up studies to see if that's the case, if there's predispositions, if you have emphysema versus chronic obstructive pulmonary disease versus different types of asthma or different types of pulmonary fibrosis. I think that's the emphasis that Dot had earlier, that until we know better who is safer from acquiring coronavirus, that we have to be very careful moving forward. And Amy, one of the questions that did come up is that I think is probably timely is one person wrote in that two family members were recently diagnosed with idiopathic pulmonary fibrosis. So perhaps a genetic predisposition. Is there a concern that the coronavirus could actually contribute and cause IPF in the future? And I think that's a very insightful question. I'll give you my take on that. And what I would say is we don't know. We know that viruses can cause many different diseases. I don't think we know the impact of the coronaviruses and its potential participation in idiopathic pulmonary fibrosis. What we can say is that when individuals have severe respiratory disease from the coronavirus or any other virus, whether it be influenza, it often leads to a condition called acute respiratory distress syndrome, which causes overwhelming damage to the lung. And in a certain subset of those patients who are on the mechanical ventilator, where we're helping breathe that for them, because of the injury to the lung, as part of the healing process, they can develop fibrosis. We think that's a different type of fibrosis than what we see in other patients with what we call interstitial lung disease or pulmonary fibrosis, the vast majority of our audience. It doesn't really demean the impact of the disease, because those patients can, if they survive that overwhelming lung injury, they are debilitated. But typically, their disease and their fibrosis does not progress, in contrast to patients with idiopathic pulmonary fibrosis or scleroderma-associated fibrosis. So we think they're different entities, but it's something that we're going to continue to look at as we learn more about this disease moving forward. So maybe just like Ryan and Amy, perhaps your perspectives on that question, because it's very insightful.
I agree with you, Greg. I think it's going to take time. Remember, this is a virus that only emerged in human beings in the last few months. And so I think we do think that in a lot of cases, the development of pulmonary fibrosis does take quite a long time. And so could this be an inciting injury? Possibly. But I think that, it'll take time and some further investigation, and probably following people who have had COVID-19 and particularly those who have had lung injury related to it, to see what happens in the long term.
Yeah, I would agree too. I think for a lot of these processes, whether it's inflammation or other things going on in the lungs, part of the process of fibrosis is kind of abnormal healing or repair. So, is it possible? Yes. We'll just need more time to know what the long-term implications are of this process for these patients.
Thank you so much. I thought it was an insightful question and good time in the presentation to address it. So I think the slide you have up, Amy, is very telling. We know that individuals with who've been exposed to.
Oh, well, until we get Greg back, I think he was saying that we know that patients with chronic respiratory diseases, and this is from a Chinese cohort of patients that had COVID-19, those patients that had underlying chronic lung illnesses had a higher disease burden, higher mortality than the population that didn't have any underlying problems. And so that is certainly what we experience and what we see happen in patients with chronic respiratory illnesses like pulmonary fibrosis with any type of acute medical illness, which is why we're so cautious with preventive care like influenza immunizations and pneumonia vaccines and things like that. So this is something that I think our community is familiar with, even though it's a new disease process. And similarly, the people of more advanced age certainly have more trouble recovering from COVID-19. I wanted to take an opportunity to just make sure that everybody's aware that the Pulmonary Fibrosis Foundation does have a page for COVID-19 resources, just trying to address some of the questions that people have that may be more general, but also pulmonary fibrosis specific. We have a frequently asked questions and some guidance statements there, and hopefully some useful resources that people can access there on the website. It's very prominent and easy to use. So as I mentioned, we got a lot of questions about, thank you for the general information, but what about pulmonary fibrosis specifically? So we wanted to talk a little bit more about the specific impact of the COVID-19 pandemic, as well as the disease process itself on our pulmonary fibrosis patients. And, I took this to mean sort of indirect and direct effects, meaning that there are effects on everybody, and particularly the pulmonary fibrosis population, that we're experiencing differences and changes in our lives that have nothing to do with actually having the coronavirus, but we're all being impacted in some way. And so we wanted to acknowledge that and talk about life being perhaps the simple life at this point. I've heard people refer to it as that, meaning that, our social schedules and the things we used to go out and do, maybe some of those external distractions might be gone. But just because life is simpler, it may not be easier. And so, Dot referred a little bit to this. But Dot, can you comment on that idea that maybe we've kind of moved to the simple life, but it's not exactly easier, and maybe a little bit on what your general I don't like to use the word disaster, but that's kind of what we refer to as disaster planning. So backup plans for what if this and what happens if that you think about.
Yes, absolutely. And this is, this is why this webinar is so important, because there are a lot of us patients and non-patients. My mother doesn't have pulmonary fibrosis, but she also, being an old elderly, she has to have a backup plan. So both of us together are kind of in this boat. And just like a lot of, our friends that are out there with, pulmonary fibrosis, they have a loved one or someone that's with them, that's caring for them, and they need a plan for them. Because I'm like, my mom and I have this constant back and forth. Mom, if you get sick, then I can't, you're going to be in the hospital. I'm not going to be able to go see you. And if I get sick, I'm going to be in the hospital. You're not going to be able to go see me. So we're, extra vigilant and extra careful like never before. But our backup plan is like, okay, well, who do we have? So thankfully, we do have a couple of people that are available and ready to help us, to care for her, someone that comes once a week to clean for us and just make sure everything's sanitized. But we do have someone that is ready, and as well as family members. So we have our certain family members that are ready to care for her if I'm in the hospital, and vice versa, to help me when she's in the hospital. I have one added benefit is that my niece works at our hospital, the transplant ICU. So she works actually with COVID patients. So we kind of have a little one-on-one with her, and she's like, y'all don't want to get sick. I promise you, you want to try to, just stay as well as you can. But thankfully, at least we have some connection there if something were to happen. But it's it's still scary. We're here at home and we're cooking more, but, we're also, understand that, this is something that we definitely have to be super vigilant about. And just, try to encourage those around us as well. We try to encourage our support group, friends and our non-ones, our family members that are looking to us and, and asking us, what should we do? And what's wonderful is that there's so much information out there to help us, the social distancing, to be the extra cautious, sanitizing everything, when you go out. I'm still in awe at how many people we still see out and about, just driving that aren't wearing masks or aren't, sanitizing. So those are the people that we have to be cautious about, but we try to continually reiterate that to those around us in our group. And as far as like if, death happens, I know I hate to say it like that, but if something were to happen, one of us passes, we already have a contingent plan for that. And we are, like I said, we are always updating it. It's a plan for me, myself personally, that when I travel, I just update, my will and make sure that that's noted. And, mama's doctors know that, she already has, an advanced directive, and just to make sure it's easy. And I found in a lot of our friends that it just makes it so much easier for our loved ones so that they don't have to make a decision if we're on life support, and they don't have to make that decision. What do we do? So it's just helpful. I think it's considerate for our loved ones that they won't have to worry about that, because I feel like they're going to be worrying about, they're going to be grieving our loss, and they're not having to make that extra added burden. So those are some of the things that we think about and have been planning on, especially now.
That's great. Thank you, Dot. And I think we always encourage people to plan ahead and think about worst case scenarios, plan for them and hope for the best, and always have a backup plan. So I think that those are great. That's great advice. Really, and it's such a blessing to have a network of people that you already have identified that can help and can take care of things and really serve in that capacity for you. Wanted to move on a little bit to talk about the care in the time of COVID-19. Ryan, could you talk a little bit about telemedicine and the visits that are happening now that people may be newly exposed to?
Yes, thanks. So I think we're going to be seeing a lot more of this now, and this may be something that'll be beneficial for even down the road, and it may be a big benefit for us to be able to do telehealth. And I've done a number of these visits with patients, and I really enjoy it. I think everybody is having a tough time right now, and that COVID-19 is affecting people in all walks of life. And it's nice to connect. I think as providers and physicians, we miss seeing our patients, in person and hearing from them. And just as we worry about our family members and friends during these times, we worry about our patients. So it is really nice to connect, especially if we can arrange for, a video visit so we can physically see them. A lot of these, I really enjoy hearing what people are doing to get the time by, also what they're, struggling with. I think it's just a great time to check in. And what I've found in a number of these that I've done is that, we are able to accomplish a lot of the things that we may be able to do in a typical in-person visit. So some of the pros is that, there's now a role reversal. Instead of the patient coming to the doctor, it's nice that we can now come to the patient, and patients can, go through their visit in the comfort of their own home. You don't have to worry about arranging for somebody to help you get to your appointment, or maybe they have to take off work to get you to the appointment. Traveling with oxygen, I think, is always a burden, and you worry about, are you going to have enough to get there? I've never found a hospital that is easy to navigate through. So just getting whether it's parking, then paying for parking, all those things are kind of lifted by being able to do these visits. And for the visit itself, I think one of the nice things is that, we can spend a lot more time, it seems like, talking about symptoms and, just discussing things. I think whenever it's an inpatient or in-person visit, sometimes there's just kind of the hustle and bustle of the visit, but I found more, just kind of connection and talking about, how people are really feeling. So I think there are a lot of advantages, and, this might be something that hopefully, for the patients that are traveling, 2-3 hours for their visits to see a pulmonary fibrosis, specialist, if we deem that maybe an in-person visit isn't, necessary, hopefully in the future we can do these even after COVID-19 is long gone. So I think there are a lot of upsides to these visits, but there are some downsides. I think part of this, just from the get-go, is implementing the technology both in the clinics and then on the receiving end for the patients, whether or not you have a good, internet setup or cell phone reception or have a camera. So I think those are always going to be limitations when there's technology involved. Some of the other things would be that new patient visits, I think, are going to be a little bit more challenging. A lot of times that first patient visit is one where, there's a lot that is discussed, and there are a lot of things that are really important from a physical exam standpoint at those initial visits. So that may be a challenge for those. The other thing would be, being limited in some of the objective measures that we use to monitor disease. So, we're not able to do a physical exam. Pulmonary function tests we follow very closely to know whether or not things are progressing or if they're stable. So it is sometimes hard to provide guidance without these objective measures. Not being able to, check labs or perform CT scans and things like that are limitations. But I think, I guess if I could provide some tips for a successful telemedicine visit, whether it's video or by phone, it would be to, I think a lot of our patients have pulse oximeters at home. It would be, if you have that and have a blood pressure machine, maybe getting your vital signs, your blood pressure, your heart rate, and what your oxygen saturation is prior to the visit would be nice or helpful. Having a list of your medications that need refilled. A lot of medication refills can be done throughout these visits. Writing down questions. I think a lot of people have questions, but having those written would be kind of another thing that would help you get the most out of your visit. And I think it's important to, share your vulnerabilities and share some of the things that you're struggling with. Because I think it's a good time to talk about the things that worry you, and talking about those with your doctor could give you guys some rapport and help guide you for, how to proceed. And then the last suggestion would be to end with something positive. I think this is a hard time for everybody, but, I think sharing, what you're doing for enjoyment or something you enjoy about, not having to travel for a visit, or what you're doing for fun or different during this time, because it is good to just kind of pause and step back and reflect on some of these, more positive things of having kind of a slower, more simple livelihood at this present time. So I don't know if Dot, if you've had any telehealth visits yet or virtual visits, are there any other things that you can see from a patient perspective in this regard?
Well, definite pros that as to what you mentioned a lot, the parking, the traveling, finding someone to go with you, someone to drop you off, the waiting, just waiting in the area, not knowing if the person next to you is sick and catching something. So as far as pros, there's like a gazillion of them. And I think it's more of a one-on-one with your doctor because that you have their undivided attention. Not that y'all are little, but there's a lot of interruptions even when you have, go into the office visit. So it is definitely so welcoming for us.
I would agree. For some reason, I feel less distracted with my phone or virtual visits than sometimes what I am in clinic. So I totally agree with you.
Hey, Ryan, this is Greg. I'm back on.
Hi.
Hey, I'm glad you guys can hear me again. One of the questions that came up through the chat line was if individuals, how do you tell the difference if you have PEF and you're exposed or you're concerned about having COVID-19 or other things like it's allergy season now. So what if you're getting a cough and more breathless? How do you try to differentiate those things? I think a lot of patients are nervous. Is it COVID-19 or is it seasonal allergies or another reason to be breathless?
Yeah, I think that's a great question because I think that's, probably somewhat of the limitations that we have with that visit is, there are things that patients feel like more short of breath. And, it's hard to know whether or not their subjective shortness of breath is corroborated by, an objective decline in their pulmonary function test or a change in their imaging or oxygen saturation being lower. So some of the things that you can do at home for those that have pulse oximeters would be to see if maybe your saturations are running lower than what they normally do. That would be one thing. And the other thing is, for a lot of the pulmonary fibrosis patients, I feel that they're pretty in tune, with their body because they've, because of this disease process of they pay extra attention to things. And I would say even more so now, you need to kind of listen to your body and let us know when something, is off. And we can try to see if we can delineate certain things that help guide you as to whether or not this would be related to something like COVID-19 or something entirely different.
The other symptoms and signs are important too. I think we're starting to see that those that have progressive disease have high fevers, but that's not always the case. But some of the cohorts in China and then in Seattle and now we're seeing them in New York are documenting diarrhea as a more common symptom. And then one that really stands out to me is when patients lose the ability to taste or to smell things. And that seems to be very common in patients who develop severe coronavirus infection. So that might key into patients if they have those symptoms early that's something they should discuss with their doctor as well. We rarely hear in fibrosis clinic, I can't smell nor taste anything. So that's a new event in most people's lives.
That's a great point. I'm going to pop back to just the sort of indirect effect, and then we'll shift back into kind of the direct effect of COVID-19 on pulmonary fibrosis. But getting back to the idea of utilizing telemedicine and the things that we can't really accomplish very easily in a virtual space. We've had a lot of questions, and as medical providers, we're trying to figure out on our own how long is too long to go without doing these certain types of assessments. And so for different specific situations, that is going to be, that really is going to be kind of patient specific. But in general, I think most of us would agree that we really can't defer lab testing that's being used for safety monitoring for new medications such as antifibrotics or immunosuppressive therapies. We can't put those off indefinitely. And so working with your doctor and your clinic to determine how long can that be delayed safely, and that some of that probably has to do with how long you've been taking a thing and when was the last time it was checked and were they okay at that time. and helping to try to make that decision, and then working to try to figure out a mechanism by which to get those lab tests drawn in a way that is as safe as possible for you, because we don't want to trade off not getting COVID-19, but having having a safety problem with not being able to monitor for for our lab tests. Next, there's a lot of centers, most centers around the country have delayed any non-emergent imaging and other types of procedures. And so that's another thing where we want our patients to make sure to work with their providers and understand why an imaging test is being ordered, such as a CAT scan. Is that being done because a certain amount of time has gone by and it's reasonable to have another look for progression? Or was there a more acute indication? Or was there something specific that was being followed that has sort of a timetable of recommendation associated with it, such as a pulmonary nodule or something like that, where there might be a window of time where we really want to get this done? And to work with your clinic to make sure that you're getting things done, again, in as safe an environment as possible, but that we're not delaying appropriate care or time-sensitive care in a way that we ought not do. And so this is something that, again, your doctors and care teams are constantly trying to make sure that we're making the right plans for you and balancing safety with the longitudinal care. For pulmonary function tests, I know everybody's used to getting them pretty frequently in their office visits, and perhaps a lot of you are saying telemedicine. Yes, no pulmonary function tests, because they can be a lot of work and very exhausting. At some point, we're going to feel like people need to have their pulmonary function tests, particularly in those patients who are having medications altered or adjusted on the basis of those test results, and perhaps when the biggest peaks in certain areas are over, that's the time when I think, depending on the center, depending on the patient, depending on the need, we'll start to make decisions about when those in-person visits are really necessary to help us make decisions about the interventions and to inform how our patients are progressing. Greg, do you have any thoughts on those kind of routine monitoring types of visits?
Yeah, I think it's challenging, and maybe to sum up what you said, it's really a risk-benefit ratio. So it gets back to the value of to any testing versus the potential risks, and it really is regionally different. Certainly, if you're in New York City right now, the risks are significant for traveling and going into a visit. Perhaps that's not the case if you're in less impacted states. So it's really a discussion, and everyone's situation is different. You can imagine if you've been stable with your disease for 2 years, in contrast to someone who is just diagnosed and maybe is having progressive symptoms. And so I guess the point, as we always mention, the disease, pulmonary fibrosis, affects different patients in different ways, and the care is individualized, as you said. So we have not been doing them in my patients here in Denver simply because the risks were higher than the benefits. And fortunately, hopefully we can get past and move back to more traditional care in the future. But that's the current status of where we are right now. So it's challenging for both physician and nurse, and as well as the patient. So as Ryan said earlier, it's all about communication and making sure we're all on the same page.
That's great. Thank you. Ryan, would you talk a little bit about, the transplant operations and maybe a little bit about the specialized visits like new consults and some of the research visits?
Yeah, thanks. So, the transplant workup is really going to be pretty unique to the individual transplant centers. I think certain places are handling these differently, but I think similar to most other things, it's a lot of risk benefit of in-person visits. And, a lot of it right now is those patients that are stable. If they have ongoing kind of transplant checklist workup items, I think those are being delayed. But again, it's kind of a very case-by-case scenario. In certain instances, if somebody is, progressing more rapidly, they might admit the patient to the hospital to complete their workup. But I think in general, it's kind of requires a lot of communication with your transplant team. And I think they're going to help guide patients on, how best to proceed and kind of have that conversation of, okay, this is how things are going. This is what we can do. This is something that we can hold off on and kind of be there for you. If things do progress rapidly and something needs to be done now, I think in some instances it can be done. Some of the things that everybody can do and what we're encouraging a lot of our patients would be to, find a way to maintain some degree of physical activity, in the home, because a good part of the pre and post-op workup and management for transplant patients is pulmonary rehabilitation. And just as clinics are closed, pulmonary rehab centers are closed. So, not totally taking this time off to be away from pulmonary rehab. I think there are certain things that people can do, whether it's using web-based platforms or YouTube, where that you can look up or search for pulmonary rehab for chronic lung disease and try to find that there are things that you can do in your home to stay physically fit so that once these things are lifted, you're ready to get right back in and as part of your workup or and management. So that's a lot for the transplant world, but I can't emphasize enough the importance of just kind of having that open communication, and then not having any major setbacks by getting sick, or you don't want to necessarily let your diet and those things get away from you while you're quarantined, because those are going to be important things to maintain your personal health, to make yourself the best transplant candidate possible. And I think that's mostly for transplant. And then new consults, as I touched on earlier, I think those are going to be a little more challenging, but I think there are things that can be accomplished during a telehealth or virtual visit. Some of those things would be collecting all the information and testing that you've already had done at outside institutions if you're being referred to a pulmonary fibrosis center, and getting the appointment scheduled down the road so that you can have an in-person visit. As far as research visits go, I think, that's going to be another area where you need to be in good communication with the study team, whether it's the research coordinators or the investigator. And those are also going to be held on a case-by-case basis. I think a lot of visits are trying to be figured out how essential certain aspects are, which things can be delayed. So I think if you are involved in a clinical trial, I'm sure they've already reached out to you of how they're handling this situation. So they will guide you best on, some of the essential things that maybe need to get done, whereas other things may be put on hold for certain studies.
That's great. Thank you. And I can certainly attest to the fact that, the research organizations are taking this very seriously and, thinking very critically about what is necessary and appropriate in a time like this for our research patients. Just to transition a little bit into the direct effects of COVID-19 infection on our pulmonary fibrosis population, we brought up some of the symptoms. We talked about that a little at our last session and just earlier. We've had questions about the course of a coronavirus infection. I think that's highly variable. We understand that there are a fair number of asymptomatic cases, and And oftentimes, there are people who are minimally symptomatic who may never know that they had COVID-19. On the other hand, there are certainly people on the other end of the spectrum that become infected and progress to very serious illness. And so it really is kind of a spectrum, and it's kind of it's very hard to know, even though we know who has higher risk of that more severe infection. It's very challenging to predict, and I don't think we have a good prediction model for who at the beginning of their course of illness is going to be more sick. And so should one of you get COVID-19, unfortunately, what I think most of us would recommend is, depending on the severity of illness at the time, and Greg and Ryan, please feel free to weigh in on this, that is when we would consider whether or not a person needs to be in a hospital, not necessarily on the basis of being infected or not, but based on the effects on the body and how sick a person actually is. And we know that the disease can start as a more mild illness and progress. And so what we would do is to have some very frequent touch points by phone or by video conference visit to check in with a person and make sure that they're still doing okay and don't need, if they're managing at home with supportive care, don't need to later be admitted to a hospital. Greg and Ryan, do you want to comment on that?
Yeah, I think a lot of this, as you touched on, was dependent on kind of the severity of illness. I think in taking care of a number of these patients, there are some that have comorbid chronic lung conditions that get COVID and they do just fine and they can stay home. Others with no underlying lung conditions can, develop symptoms and progress rapidly. So I think it's very individualized care, very individualized kind of treatment plan. And again, it's kind of a lot of communication. And just because you would get COVID-19 doesn't necessarily mean that you would need to be hospitalized, but I think we'd have to watch things closely.
It's a really great point. The way in which it affects everyone is quite different. And I might clarify that we know that patients with chronic lung disease are in a higher risk category. And I'd underline risk. Doesn't mean that if one is infected, you're going to have severe progressive lung dysfunction requiring a mechanical ventilator, and that's what we see on the news. But we know there's a risk there, so we always try to reduce that risk as best we can so that we can prevent problems. But that leads to the anxiety, I think, whether you have lung disease or heart disease or diabetes, we're all concerned about if we were to get infected with the virus, how would it impact us? And until we know more, we have to just be careful to prevent the infection and should it occur, to monitor things very closely and be in communication. So every day we learn more. And as Dot has always said, you just have to be prepared and be as careful as possible and then move forward. And so it's a learning process for everyone.
And I think some of the preparedness that is important with this is, being prepared before you would get COVID-19 and know that if you were hospitalized for this, that all hospitals have very restrictive visitor policies. So you want to talk with your family, your friends, and find ways that you may stay connected during that time and potentially designate family or friends to be the primary communicator with the medical team so that, you're avoiding confusion and so that there's good communication. And then also, this is where it's important to kind of have some of your advanced directives outlined, before you would be admitted to the hospital so that, your friends, family, caregivers know how you would want to be, treated in a variety of settings to take some of the stress off of them. And also so that, as a medical provider, we want to make sure that we're doing right by you and that we're honoring your wishes. So I think preparing those things ahead of time would be very important.
I would echo that and say that. Oh, go ahead, Pat.
Oh, I just wanted to interject. I'm listening to, you wonderful, amazing doctors, and y'all are helping us and encouraging us. But at the same time, I feel like from a patient perspective, would like to share, don't let it paralyze you either. We can't let, COVID-19 paralyze us to the point where we're just, terrified and not enjoying the life that we have now. So just please be aware that just like when we're diagnosed with pulmonary fibrosis, to just still enjoy every day, get up every morning, keep your routine, keep doing what you're doing because it's kept you well up until this point, till today. So just don't let it paralyze you. I'm so grateful for this information, and we do need that plan B, C, and D, but don't let it paralyze you. Don't let it keep you from enjoying today. So in the midst of the craziness of COVID-19 and the preparedness and the awareness and the education, let's also remind ourselves as patients and even caregivers, it's going to be all right. We're going to make it. We're here today, and let's try to make the most of today. And if it happens, let's not worry about it right now. Let's plan for it, but when, or if, not when, if it happens, then we'll deal with that at that moment. But just enjoy today. And I really, as a patient, we really appreciate this information, and we need this information. But also, just an encouragement: don't let it paralyze you. It could be scary times, but don't let it paralyze you or hinder you from enjoying today, just like you have every day. Thank you.
And Dot, I think that's great information, because I think part of it too is, with all of this going on, is to, it is good to stay informed, but it's also, there's so much on social media, news, and unfortunately there's a lot of worst case scenarios that are out there. So I think staying informed, but also maybe limiting some of the time that you're spending on those platforms, seeing information about COVID-19.
That's really great advice. I'm going to sum up what Dot said by saying, have a plan B, but enjoy plan A to the fullest. Does that sound right?
That's perfect. Absolutely perfect, Amy.
All right. I'm going to shift a little bit. We had some questions about, treatments for COVID-19 and what's new. And we've talked a little bit with this group of presenters about how, the pulmonary fibrosis community has been, for years and years was waiting for effective therapies, and we're still waiting for the cure to come along, and we're waiting for new research. We're waiting for new drugs to be developed. And in the face of a severe illness. And now I think the whole world is experiencing that impatience that the pulmonary fibrosis community has had for such a long time. And so, I hear about this every day. I see this every day. There's a lot of anxiety over, these new therapies, and everything that comes along that has any biologic plausibility seems to make it to the nightly news. And so I thought what I would say, first of all, is that unfortunately to date, unless something's been published in the last couple of hours that I haven't seen, what we don't have is a known effective specific therapy for COVID-19. And what we know to do is best supportive care. So as critical care doctors, as pulmonologists, as hospital doctors, and as outpatient doctors, what we know works is are things like preventive care, supportive care, best care for sepsis, for acute respiratory distress syndrome, for hypoxemia in the hospital, things like that. And we're doing that to the best of our abilities for our COVID patients. And there is an unprecedented level of collaboration and coordination and acceleration of research in this space like nothing I've ever seen in my career. But so there's a lot of work happening, but I think we still have to let that scientific process play out to get to the right answer for COVID-19. So you'll see where hospitals are using some of these therapies on an experimental basis in clinical trials, And all of that is very exciting and very interesting. And I think we're all waiting, from patients to providers to the viewers of the nightly news. We're all waiting for the announcement that something has a positive large clinical trial result, and will give us some hope that we have a specific therapy to help patients. One question we had was whether the treatment approach for a pulmonary fibrosis patient with COVID-19 would differ from a patient who doesn't have pulmonary fibrosis. And I think in general, the answer to that is no, not really. I mean, I think we would have very similar thresholds for hospitalizing, for potentially enrollment with some of these experimental therapies and things like that. And none of that best supportive care that we know helps in severe and critical illness would change necessarily on the basis of the presence or absence of pulmonary fibrosis. I would say I wanted to sort of cap off the discussion of new therapies by telling a story that is relevant to the pulmonary fibrosis story about why clinical trials and letting the scientific research process play out before broadly adopting experimental therapies. Years ago, in 2005, was published a study in idiopathic pulmonary fibrosis. And this study looked at patients over time, and these patients were randomized to one of two arms of therapy. One was prednisone, azathioprine, and N-acetylcysteine, which is an antioxidant. Many of you may have heard of this. And the other arm of patients got prednisone and azathioprine. This was back in 2005. So you remember that there wasn't any other antifibrotic therapy available. And what we were doing for IPF patients at that point was truly best supportive care. There was no specific therapy available and nothing that was particularly recommended. And so what the research in this study found was that those patients who had the combination of three drugs did better over time with regard to their lung function than those patients who got two drugs, prednisone and azathioprine. And from that, there was, in a lot of places, broad acceptance of prednisone, azathioprine, and N-acetylcysteine as being the standard of care for IPF patients. However, what was not done at that time was any type of placebo or best supportive care approach. And so what we didn't know was what was happening to these patients who were not getting either of these therapeutic arms. So some years later, I'm old enough to remember, that the IPF network put together a study to try and answer that question. Now, this graph is flipped upside down from the other one, and so better is on the bottom instead of on the top here. But this study, the Panther study, you may have heard of, looked at, these are two arms of a three-arm study, but these two arms looked at patients with IPF who were on a true placebo arm. They didn't get anything besides best supportive care and a placebo medication, and prednisone, azathioprine, and N-acetylcysteine, which, remember from the previous study, was what seemed to be better. And as it turned out, that those patients who were getting that three-drug combination actually had worse outcomes in terms of death and hospitalization as a composite endpoint. So I think that I tell that story because, as it turns out, that the thing we thought was better, if there were a placebo arm on this graph, perhaps it would have been higher than the prednisone, azathioprine, and acetylcysteine arm. And when we answered that question, asking it a different way, what we found out was that something we adopted was potentially harmful to patients and made us think, I think, differently about the way we study things in IPF. So again, I tell this story because I think there's a lot of impatience, and that same impatience that we in the pulmonary fibrosis community feel about new and better treatments. This is the same thing people are feeling now in the COVID-19 crisis. But it's so important to make sure that we're studying these things in a scientifically correct way and giving that the time that it needs to play out. Greg or Ryan, do you want to make any comments on that? Did I tell the story right?
This is Greg. I think it's really applicable. The comment that a lot of people have made with COVID-19 is, well, why don't we just try the hydroxychloroquine? How could it hurt anyone? And the answer is it could. And just recently, over this past weekend, there was demonstration of harm in a Brazilian research study where they gave every patient the hydroxychloroquine, and they started to identify the known side effects, which were toxicity to their heart. So even though drugs appear safe until you study them, it would be horrible to give someone a drug with good intent, but to have them suffer from a completely unrelated problem like their heart when they're suffering from COVID-19. So it's we want to be aggressive, we want to be appropriate, but we really want to make sure that first and foremost we're not hurting patients while we're trying to help them. And we prove that the treatments are really helpful and safe. And so it was a tough lesson to learn with azathioprine years ago. And I did prescribe that to patients. And when we did the right study, it was, I think, one of the most significant studies we've ever done in the pulmonary fibrosis community, because we stopped hurting patients first and foremost. And then it allowed us to move forward and identify additional treatments that are truly helping patients. So I think it's a great example of the right way to do it. We just need to do it as fast and safe as possible.
Absolutely. So I think we have just a few minutes left. We planned this for about an hour and a half, and we do have a few minutes in case people have questions that we can try to address. If you have a question, I think you can type it in the chat box or the question box, and we'll try and get to some of those. I would like to go ahead and say that I know there are also questions about testing and perhaps even how long is this situation going to last, and what is the new normal going to look like on the other side. And I think we're learning more about that, but I think there's still a lot of progress to be made. And hopefully at a future session, we can have a lot more information to at least food for thought on the duration and what life is going to look like. And then probably a lot more information as rapidly as things are developing on testing, in particular the antibody testing aspect. Greg, do you have questions that people have submitted?
Yeah, there are two questions, and unfortunately I don't know if we have answers yet, but I'll put them out there. A very important one was, what's the possibility of someone surviving COVID-19 if they have interstitial lung disease? And the second is, in our community, patients with pulmonary fibrosis, how long should we anticipate the quarantine and social distancing be implemented over the next period of time? And I might take a stab at both and open it up to you guys. I don't know if we know the answers to those questions right now. I think we kind of alluded to the fact of not everyone who gets infected with the coronavirus develops severe lung disease. And so we just don't know, but we want to make sure that patients prevent infection as the first arm. But should they get infected, we don't know what the long-term outcome is. We certainly hope that they don't develop progressive disease. And boy, the second was $1 million question. How long is this going to last? Even the brightest and the best in epidemiology and public health, like Dr. Fauci, I think they're very cautious. They're very optimistic to see the impact of social distancing. It's been very helpful. I think we need new tools. We need to understand who's been infected and who might have immunity. That's the best question. And more people that have developed protective immunity or even partial protective immunity then that might help prevent infections from spreading as rapidly as we've seen over the past couple months. But boy, it is a great question, and I don't know if you, Amy or Ryan, have more insightful answers, but I wish I could definitively say what date everything will return to normal, but I don't think it's out there yet.
That certainly is the million-dollar question.
Yeah, I think the one truth of it is that when things do open back up, it will probably be a gradual process. So, I don't think it's going to be all of a sudden abrupt that things all go back to normal. I think things are going to be changed forever in how we do things.
Those are great questions. We might give it another minute to see if anybody else has any questions. But Greg, do you want to mention our next planned session?
Sure, and then Dot raised a question. Lindsay and Jennifer, part of the communication center at the foundation, have been interacting with a lot of individuals over the past 6 to 8 weeks, and they have planned or are planning a session to give us a little more time to get more information about COVID-19 and have our third in this series. But a session on mindfulness and introspection, so that we had a wonderful session at the PFF Summit in November with thoughtful writing and introspection, and it was the highest rated session at the summit by our patient attendees. It gives you a way maybe to think about the things you value and that you're happy about, kind of like Dot said, focus on plan A, but have a plan B, and appreciate everything that maybe we have the opportunity and time to sit back now that we're distancing from one another. And so we'll be announcing the exact time moving forward, but the response of the community was overwhelming, at least at the summit, and that seems like a really great opportunity and an appropriate time for us all to think about the things that, as Ryan said, that we're appreciative of, and really move forward and help with our emotional support, not just our physical support. And Dot, your question was very timely. What do you do if you develop COVID-19 or you think you have had COVID-19? Is there anything that you should do in particular? I might leave that up to you and Ryan, Amy. So if you think you've had the disease, what do you do next?
Well, so I'll tell you what we have talked about with our patients, which I don't think we've had many people have concerns about that in our population, because everybody has been, again, so incredibly cautious, which is so commendable because it's very hard. But I think the advice we've given is that we want to try to, try to get some sense of how symptomatic a person is, their respiratory status, and their oxygen saturation, and try and make a decision if that person might need more emergency room type care, or if they can have some kind of close follow-up at home. The testing situation for COVID-19 is really variable across the country, and it's gotten a little easier in our area, but that is something that's going to be very individualized based on your location and the accessibility of testing, particularly in the outpatient setting. And so that's a decision that needs to be made, with your doctor or your care team. And then, my recommendation then is to make sure that we are, as a medical team, if a person is not necessarily sick enough to go to the hospital, because that's something that we think, very closely about now, whether the, risk of being in that hospital environment is needed, instead of just saying, well, just go to the hospital and get checked out, let them figure it out there. We try a little harder to figure it out, if we can, without making that trip, because it's not zero risk at this point. And so then deciding about whether testing is appropriate, but certainly having close check-ins from our medical team with our patients who are ill from suspected COVID or otherwise, to make sure that we're keeping a handle on folks and giving them good advice about when they might need to be seen, or whether that we know and document when they're getting better as well. I think that was all I was going to say. I think my last piece of advice there is call early. Don't wait. Ryan, what do you think?
Yeah, I think I would echo what you said. I touched on it a little bit earlier. I think it's kind of a very individualized scenario of looking at the risk benefits of each individual patient, of whether or not they should go into the hospital or whether they can self-quarantine at home. And I think just, being a little hypervigilant in monitoring, but just kind of a case-by-case decision on how to proceed. And I think a lot of hospitals have protocols in terms of how they're doing outpatient testing, and some of that depends on, what area of the country you live in and what your accessibility is to those things. And similarly with inpatient kind of management protocols. So I think just, again, a lot of this is open communication with your pulmonary fibrosis team to kind of get the best optimal care for you.
I would also say that for most clinics, if they are still open and seeing patients, they are probably not going to allow a suspected COVID-19 patient to come in to be seen. So if a person does need a more urgent evaluation, then in I think most cases it's going to end up being in an urgent care or emergent type setting. Do you guys have that same type of rule in place?
Yes.
Yeah, and a lot of the testing is kind of off-site completely, and kind of have a hotline that people call in and are screened, and if testing is deemed warranted, they're kind of told where to go. So
yeah, I think most places have intentionally moved testing outside of their clinics, so that if somebody came to my clinic and I thought they had COVID-19, I don't have any way to test them in the office. They would have to go to a testing collection site.
And Amy, there are numerous questions, and unfortunately we won't be able to get to them all in this particular webinar. One common question that seemed to run through was, if you're on one of the approved therapies, the antifibrotics, either nintedanib or pirfenidone, does that help prevent or potentially treat infection, fibrosis associated with COVID-19 infection, or prevent progression if you have the underlying disease? And I might take that question. I know that there are ongoing studies to try to address that. The fibrosis that occurs in COVID-19 may have shared mechanisms or similar mechanisms to what we have seen in some patients with different forms of pulmonary fibrosis, whether it be idiopathic pulmonary fibrosis or other forms. But we don't really know that they provide protection or treatment in individuals who might have COVID-associated lung injury and fibrosis, or vice versa. Do individuals who are being treated for various different forms of fibrosis that are on those medicines, does that help or protect them? And unfortunately, we just don't have answers to those questions. Obviously, I wouldn't recommend anyone start treatment with an antifibrotic agent to try to prevent COVID-19. I think you would start treatment for your pulmonary fibrosis for the appropriate reasons. It's a great question, and it's one that I think a lot of people are asking in the research community, and there are ongoing studies to try to address it. And I think I share your enthusiasm, Amy, that the degree of collaboration and the barriers to doing research have broken down, both at the NIH with pharma sponsors, to really just make things happen as quickly as possible to find an answer to treat patients as effectively as possible. And so I think, as Ryan says, it's always good to end on a positive note. And I would say, It can't happen fast enough, but I'm tremendously excited to see the number of people that are working together to try to help everyone in the community, our pulmonary fibrosis community, and communities across the country and the world in general. Everyone is doing everything they can to try to find an answer as quickly as possible. The only limitation right now is, I think, time. We just need more information and more time to definitively identify the best treatments moving forward. And I would like to apologize that we can't go through more questions, but as Jennifer and Lindsay will do, we'll catalog them, and it'll form the foundation of the next in this series over probably towards the end of May, as we allow time to get more information moving forward and have more appropriate presentations. So I'd like to thank everyone, in particular Delarosa, who in my mind is the PF cheerleader. She has such great insight and great positivity, as well as you, Ryan, and Amy. Thank you for making yourself available during this challenging time to be a critical care physician and caring for patients. So it's quite a luxury that we have you on the call today. So I thank you on behalf of the Pulmonary Fibrosis Foundation, as well as all patients and caregivers that are on the call today.
Thank you, Greg. Thanks, everybody. Bye, everyone. Stay safe and wash your hands.
Exactly.